Sir, who is the answering today?
Who is answering today?
Sir, Akshay Patel and Suhas. Dr. Suhas and Dr. Akshay Patel.
Akshay Patel.
Ashay, A-S-H-A-Y.
Akshay.
This
Akshay
is
Patel
so
and
true, yeah. This is exactly how we were finding too cute.
Dr. Suhas.
We did Garba.
Drawing session? Okay.
One minute, huh? Just 1 minute.
Akshay Patel and
Suhas. Dr. Suhas.
okay. Shwaz has joined with what number?
Sir, Dr. Suhas has joined by a number, phone number 95434. Please unmute him and make him host.
Rakesh, you are a host.
Yes, sir.
Yes.
I have made that number
Yeah.
co-host.
Yes, sir. Sir, the candidates answering are Dr. Suhas and Dr. Ashay.
Okay. Pankaj bhai?
And sorry, the topic name is reflecting wrong on the screen. We are sorry about that. It is instruments part 2, upper tract.
Dr. Dheeraj? Dr. Dheeraj Shah? Dr. Pankaj Maheshwari ji?
Good evening, sir.
So now, today, you have to be very active as far as all these things, because that is your domain and you are the best in this.
Sir,
So,
definitely I'll be there, sir. आप तो है ही, पर we'll be together, sir. No problem.
yes,
sir.
yes, yes. Nahin. Because you have been using since so many years, and you have helped them in so much research also.
Mhm. Sure, sir.
But we missed you in Raipur.
हाँ sir, even I missed the conference. Conference बहुत अच्छा रहा. Congratulations, sir.
Thank you.
Hmm.
And your this thing, idea of emergency. You remember? Both the time. It has really worked. Both the
चलिए,
time.
wonderful.
Good. I think we should start now.
Yes, sir. I think we are well past 9.
Yeah. Okay. So, Ashay and Suhas.
Hello.
These two
Gita
are
sir has
answering.
joined?
Yeah, Gite sir has joined, but he is traveling in a train. There
Okay.
is lots of noise around.
Yes, sir.
So he said that as and when required, he will, answer. Dr.
Sure.
Hiren is joining. He is already in the hospital. Okay, fine. Okay, so Ashay, Suhas, who is answering? Who
Yes,
will
sir.
answer first? Describe. What is this?
This is
Hello, sir. This
thermo
is
guide
Dr.
wire.
Ashay. Okay.
Sir, Dr. Suhas. This is a thermo guide, side tip thermo guide wire of size 0.035 inch. Sir. It is 150 centimeter in length.
You see, there are other information already there that it's a straight tip, it's a single-use disposable. So you could keep on adding all these adjectives.
Yes, sir.
Yeah. So Ashay, you
Yes,
have
sir.
described this. Have you told us everything? Say, we have said the name of the instrument or name of the whatever article they are showing you. Then what is it is made up of? Then what are the
Sir,
uses?
it
So
is
everything you have to say, na?
nitinol core hydrophilic guide wire, which is also called glide wire, and
Okay.
whose core is made up of nitinol, which provides flexibility. There, outside that, there is a coating of polyurethane and with the tungsten, so that it is seen with the SIAM for radio opacity. And outer to that, there is a hydrophilic material, which is a polymer, which causes water to stick to make it smooth and slippery. And oh, yes, sir. That is
So
how it
one
is
end
made of.
is
One end is a soft tip and one end is a hard tip, sir.
why it is like that?
Uh, Sir, the soft end is smooth and atraumatic. It can be used to negotiate strictures, kinks, or pass across stones like that. So there is no damage or perforation.
Because the yeah, okay. The ureter, mucosa, everything is a very delicate structure. So that is why, and it is the path founder. Means it find out its own path in the small opening and it can be negotiated. Correct?
Yes, sir.
So, but then
Yes, sir.
why there is a hard end?
Uh, uh,
No, you know, every day you are doing the procedure, na beta?
yes, sir.
So the whole the hard part, it makes the guide wire steady. And when you want to introduce
Okay,
something over
steady.
there, correct? The whole
Okay,
thing is if it is
for
soft, what will
introducing
happen?
digestants. Yes, yes.
Yeah,
It
so
will be difficult to
insertion of
introduce the digestant.
so it becomes easier. What is the
Yes,
other
sir.
use of the hard end?
Sir, the hard end we can use in PCNL when we are passing the guide wire from from the ureteric catheter down to up. When we have lost the safety guide wire, then sometimes we get the ureteric catheter inside the sheath and then pass the hard end and then do the antegrade degescenting.
All no, you I have not understood. Tell
Sir, in case we have lost the safety guide wire and we have the ureteric catheter in place, then we will pull the ureteric catheter inside the ampullates and outside, and then from down we will put the hard end and then use that wire uh, and pull it inside and coil it in the bladder and then use it for degescenting.
Better
Hello. Sir is muted, I think. Hello.
Sorry, I thought I was on mute. So the better description will be to call it as a through and through wire. Are you there? Anything happening?
Yes, sir.
What are the various types of guide wires?
Sir, guide wires can be classified according to their core. So this one is nitinol core. Then there is a stainless steel core, and there is the super stiff amplified fixed core, which is also stainless steel, but with yes, with PTFE coating. And it is a more stiff wire used in PCNL for dilatation. And there is one zebra wire, which has blue and white stripes. And there is a sensor wire, which is a hybrid wire. And there is a wire with double floppy tip.
What is that called?
Bi wire, sir. Flexible
Bi.
tip at both ends.
What is the use of that bi wire?
Sir, the one flexible tip is in ureter and other flexible tip causes less damage to endoscope while railroading.
True. Okay. और कुछ पूछना चाहते हैं सर?
No, I think yes. Okay, one more thing. Suppose there is you get a double J stand which is both the side open, but you get digestion which is only one side open, then how will you insert? Suhas?
So we can cut the tip of the closed end and
What else?
We can use the hard end.
Yeah,
to
so
break
you insert the hard
through.
end and make the earlier we used to do. Nowadays we are not doing. We use only unless and until we are 100% sure that the guide wire or glide wire has gone across the structure part or the stone, then only then we use resistance. But earlier we used to make it stiff by putting this hard end into a closed end. So the digestion becomes like a uretic catheter straight. And then we
yes,
used
sir.
to put it. Nowadays, no one is doing that. Okay,
Yes, sir.
fine. So I just missed it. Can you just enumerate the uses of this guide wire? Can any one of you enumerate?
So yes, sir. In for ureteroscopy procedures, initially to pass the ureteric catheter also, or to, before any ureteroscopy, we can put the guide wire as a safety wire. Over that, we can go push the ureteroscope one end, and for RGP, initially we can put the guide wire over that. We can railroad the ureteric catheter, and for RGP for PCNL procedures, and again for DJ stunting. And in PCNL procedures, initially before after the needle axis, before dilatation, you can put the guide wires.
So you start from the urethra. In cases of strictured urethra, you bypass it,
Yes, sir.
you pass it through the stricturous part of the urethra, and over that you can do the scopy and you can do the
Dilatation.
visual internal urethrotomy.
Yes,
Correct?
sir.
That is number one.
Yes, sir.
Number two,
Yes.
then after going inside, if the bladder neck is very high and you are not able to negotiate, again you put a glide wire and on that ureteric catheter and on that you can glide the scope. Third thing is when you go
Yes.
inside, then for ureteroscopy, correct? Or you want to
Yes, sir.
put the ureteric catheter, you want to collect urine for culture or for uh, malignant cells for that purpose, and then before doing URS, then your
Yes.
PCNL.
Yes, sir.
Which other place? When you want to change the nephrostomy.
Yes, sir.
So that is the time also you use a glide wire. Okay, so these are the basic
Yes.
case. Fine.
Yes.
Okay. Maheshwari ji, shall we go ahead?
Yes, sir.
Yeah. Fine. Ashay,
Yes, sir. Sir, this is the zebra guide wire. It is called zebra because of the blue and white stripes. It is also made of nitinol core with PT-free coating, and it is a little stiffer than the uh, regular guide wire, and it has a platinum distal tip for like for radio opacity, and yeah, it does not kink, and it is useful in degescenting in tortuous ureters, and also used for endodilatation of urethra in cases of urethral strictures, because it is easier to pass the Teflon endodilators through a stiff wire. It is kink resistant, and so better handling qualities. It also has a soft end and a hard end. So
yeah. So
it
the
also
advantage
comes in
of this
various
over the
sizes.
guide wire is what?
So the advantage is it does not kink first, and it has the tip is radio opaque, and uh, it it uh, it has better handling for passing
So in
stents and
so
passing
it is much
dilators.
rigid than the
Rigid. Yes,
guide
sir.
wire. So in the difficult cases,
Mhm.
okay, where you want to
Yes, sir.
negotiate the DJ stand or any other over that zebra, then it is easier. Second thing, the tortuous ureter can be made straight during the procedure by using the zebra.
Yes, sir. Yes, sir.
So that is the advantage. Maheshwari ji, some extra use if you are remembering.
No, sir, I think well covered.
Okay.
So this is also a hydrophilic wire, so that property is also there.
Yeah. And the advantage is this can be, which of course, all these are disposable. In exam, you always say it is a disposable, but just a practical thing is glide wire. That is, I will not advise you to use it again. You can keep it in for emergency. But if you are doing ureteroscopy or PCNL, every time, please use a new guide wire only because it is much smoother and your procedure will be much better. It will be easy to do it. But this zebra, you can use it in your practice. But in exam, it is disposable. One time
Yes,
use.
sir.
Right. Brijesh, next. Ashay, Suhas,
Sir, this is a pathfinder. It is used in ureteroscopy. It is
please,
transparent and made.
after name, you
Uh,
must describe and the
yes, sir.
material and then the uses.
Yes, sir. Uh, Sir, this is a pathfinder, and it it is made up of polyurethane, and yeah, it consists of inlet, a bulb, and an outlet, and it is used for irrigation during
No, no, you both
Hello.
different proximal and are different or not.
What, sir? Hello.
The both and
Uh,
the connectors are different.
yes, sir.
So at the proximal end, what you will attach?
Proximal end, we will attach the irrigation and uh, the source of irrigation, the TRP set.
Yeah. So either okay
And
or what else? IV set. It can
IV
take the
set.
IV set,
Yes, sir. Yes, sir. It will be guided,
and the
sir.
distal end.
Distal end will attach into the inlet of the semi-rigid URS.
So what type of
It's
system it
a
has got?
screw. It has a screw action, so it will be fixed properly over there.
It is like a lure lock, na?
Lure lock. Yes, sir. Lure lock.
Okay, fine. How it works?
Sir, when we press the balloon, there is a rush of. I
See,
mean,
on both the sides of balloon, there are valves, and it is a one-way valve.
yes, sir. One way valve.
Okay,
On the principle of one way valve. Yes, sir.
so it opens only towards the distal end.
Yes, sir.
So when you are pressing, there is a negative suction. There is a negative. The fluid will go distally, and it will have a negative pressure. So when you release it,
Negative pressure. The water will
Then the
fill
proximal valve
into the 1 by
opens
1.
and then
Yes.
the distal valve is closed. So the fluid
Close.
cannot come back, but fluid from the irrigation system can come into the
Some can come.
balloon.
Yes, sir.
So how will you use it? So before using it,
Sir,
you have to remove all
you have
air
to remove
and
the
fill up
air
the balloon.
bubbles. Yes, sir.
Correct? So
Yes,
you
sir.
fill up the full balloon, no air should remain inside. Then you attach the full
Then-
system and then you
Yes,
start.
sir. And then, yes, sir.
So tell me, what are the advantages and disadvantages?
Sir, advantages are it helps in visualization, and it helps during bleeding to clear off
Now you tell
the
me,
bleeding.
when you are doing the procedure, when you like to use it? When you are introducing
Sir,
your scope?
Sir, when introducing into the urethra, we would like to long press and go over the infant feeding tube while introducing the semi-rigid URS into the urethra and into the bladder. Then long press, and then while we are going into the ureter or ureteric orifice over the wire, we will use short intermittent presses to go inside.
What is an advert? When ideally you should use? See, normally with the normal irrigation, you can do all your procedures. So even if it is a ureteronoscopy, if you are doing it with a normal irrigation, okay, you can easily go into the urethra, bladder, and ureter. Only maximum advantage is when you're putting any instrument. So the channel becomes narrow.
Narrow, and
With the
irrigation will
normal
be-
irrigation, the enough of fluid is not going inside. So
Okay.
this is the ideal time when you should use this
use the
pathfinder
balloon.
so that there is increased pressure and you can reach to the amount of fluid. And how much you will give the pressure? Till you see the object, that is stone, clearly.
Yes, sir. Yes, sir.
You should not apply too much of force. It is very difficult to control. You cannot decide how many atmospheric pressure you want to apply or how much pressure you want to give. Okay? So slowly you press it and see and then find out.
Yes, sir.
If the vision is not clear, you can apply little more pressure. But as soon as you see properly, don't apply more pressure. And ideally, it is used when instrument is there in the instrument channel.
Okay.
So the advantage of this equipment is, I'm sorry.
Yeah, please go ahead. Yeah, so the another advantage is that when you are doing this procedure, you may not require another person to help you. With one hand, you can decide how much pressure to apply and how much irrigation to be done. That is one advantage. Yes, sir. आप बोलो जरा. Okay. What is the second advantage? So one advantage is that you may not require another person to help you. Second advantage, you can decide how much pressure to apply. Okay.
Yes, sir.
Then third, it is reusable.
Yes, sir.
Okay.
Okay, sir.
Yes, sir.
Any other use?
So as I was trying to tell you, sorry, that phone call came in between, that
Yeah.
this has an advantage that it gives you a continuous irrigation with intermittent pulsatile irrigation. So by intermittent pulsatile means whenever we feel that the vision is less or the tube in front of you is collapsing, you can gradually press this bulb so that the higher irrigation goes in. One more advantage is this being very light, even when it remains attached to the ureteroscope, movement of your scope becomes easy. And this can be managed by you yourself or by your assistant. So just you hold it in your palm and with your fingers keep on intermittently pressing whenever you feel that the vision is suboptimal. The vision could be suboptimal because of some equipment in the instrument channel, because of some, say, physiological narrowing of the ureter, post dusting if there is a lot of dust there in any calyx, or if there is mild bleeding. So in any of these situations, intermittent gradual, say pulsatile irrigation, which is over and above the continuous irrigation, will help you do the procedure. Obviously, you will not overdo this because you don't want to increase the internal pressures. Very high internal pressures will increase the risk of infection and will increase the risk of bleeding.
So, Suhas, have you heard all the points?
Sir? Yes, sir. Yes, sir. I've heard.
So can you enumerate all the points, advantages?
Yes, sir. So one thing is, even the surgeon only can handle single. There's no requirement for any other person to handle the irrigation. And one more thing is, we can decide whenever the pressure is required, and we can have a control on the irrigation. And third one is, because of the lightweight, the movement of the scope is also not interfered. It is also easy, light and easy movements are there.
Reusable.
Yes, reuse.
Yes. Now, tell me when you will do it. Sir has told you that also, when you will use it.
So whenever we are introducing an instrument, so that the irrigation
The
is
answer
slowed
is
down, that
when
time we
the,
can use.
no, what he said is that when the vision is suboptimal. And what are the causes of suboptimal vision? When the irrigation is low because of instrument, because of bleeding,
Bleeding.
because of
Yes.
infection, if there is too much of purulent urine, or if after dusting,
Debris.
if there is too much of dust and you want to clear
Yes,
it.
sir. Yes, sir.
Okay. And the disadvantage is if you apply too much of pressure, the infection can go into the
Right.
system.
Yes, sir.
You correct?
Yes, sir.
Fine. Bala, Gite sir, you want to say anything? Dr. Huddeda,
Again, theoretically, even this is supposed to be a disposable equipment.
yeah. Hiren, before we go ahead, you want to add anything? Dr. Vinit Shah, Vinit, hello. I think yes, muted himself. Fine. I think Bridges, go ahead. Come on, Suhas.
Yes, sir. This is a ureteric catheter.
Beta, what I told you, just tell us what is this. Then
What is it?
describe this. Then the material from which it is made, and then use this.
Yes, sir.
Advantages, disadvantage. Very systematically. When someone gives you this, you start that way. So what is this?
Yes, sir. This is a ureteric catheter.
Only ureteric catheter. It is closed end, open end. What type of ureteric catheter?
Open end ureteric catheter.
Yeah, so say no, it is open end ureteric catheter. Now, what are the different? What is the length of this catheter?
Then
70.
70 centimeters.
And what are the different sizes available?
So it's available between 3 to 5 French.
3 to
5,
8.
8.
up to 7 French. I have seen up to 7 French.
Yes, sir.
Okay, so 3 to 7 French ureteric catheter are available, right? It is made up of
Yes, sir.
material.
Polyethylene
Poly.
with polyethylene with radioepoxy coating.
Okay, fine. How you are going to sterilize it? It is a disposable, and how it is coming? How it is sterilized?
ETO or plasma sterilization, sir.
Yeah, usually ETO. It comes ETO. Fine. What are the uses?
Yes, sir. It can be used for uh, bulbar ureterogram or retrograde pyelogram, and even to change over from thermo to zebra guide wire in case of impacted stones before prior to stenting. We can put the zebra guide wire through the ureteric catheter.
So, will you
And
like to
to
start it
collect the,
from? Will you like to start it from urethra and go up to the kidney? If you
yes,
think
sir.
very logically for the urethra,
Yes, sir.
so tell me.
In case of urethral stricture,
Yes, you
if
want to put a glide wire across the
glide wire,
stricture. You can use this ureteric catheter. Through that, you put the glide wire and then
yes,
you put the ureteric catheter over that. So the stricture, when you are doing visual internal ureterotomy, that stricture will become little dilated, and then you can negotiate via your blade the tip easily, and you can cut it without making any
yes,
false
sir.
passage or excessive bleeding.
Yes, sir.
That is number one. So stricture urethra. Second, as I told you, high bladder neck.
Yes, sir.
Yeah. Third, urethral fistula. Suppose if there is any urethral fistula, ureterorectal fistula, then you can put this over the glide wire and bring it out from the rectum, and you can see through and through. Third, the same way, vesico-vaginal fistula.
We
Yes,
are
sir.
also using it to do HoLAP or bladder neck incision to stabilize the laser fiber.
Okay, yes, sir.
Okay, so that is up to bladder and prostate you have done. Now, as you said, to negotiate the ureter, right? To doing
Yes,
the
sir.
ureteroscopy, or you want to collect the urine for
Correct
culture,
the
sensitivity, gene
culture.
aspect, or for the malignant cells. And you
Yes,
want
sir.
to do RIRS, before that also you use it. Then
Yes,
before PCNL, to do RGP
yes, sir. Arch.
and see the calyx, which to puncture,
Yes, sir.
opacification of the renal system. Then to diagnose and treat which condition? The same time you diagnose also and you treat also. Which condition? In case of chyluria,
Chyluria, yes, yes.
Yes, sir. Childhood.
right? Then
Yes, sir.
after gynec or any other pelvic surgery, when you are suspecting damage to the ureter,
Ureter, yes,
injury to the ureter, again diagnostic.
yes, sir.
Antegrade endopilotomy, antegrade degestenting. If at all you have done a PCNL and you want to put a stent and guide wire is not
Yes,
going in, ureteric catheter will help to put it.
yes,
So what sir has done is from below up he has taken you and then he has taken you to other specialties also. So that is how you should answer. Right from
yes, sir.
urethra to kidney and then other specialties like vesicovaginal, so gynec, associated problems.
Yes, sir.
You can
But
also classify as a diagnostic and therapeutic also.
so
Yes,
any
sir.
use of this ureteric catheter in laparoscopy? Sometimes if you cannot see the ureter, how this ureteric catheter helps?
Sir, during pyeloplasty, we can place a UC to locate the ureter.
No, suppose you don't know only where the ureteric catheter is, where the ureter is. Can any light be used inside the ureteric catheter?
illuminated ureteric catheters.
Yeah, so you don't have a illuminated urethric catheter. Can you make one?
So we use the light source and
No,
use it
just
on
pass the
the
laser fiber with the beam, with the aiming beam.
Okay.
Then that
Yes,
will
sir.
be seen like a red dot. So it can help in
Yes.
laparoscopy in difficult cases. Just
Yes, sir.
pass a ureteric catheter and put a
laser fiber.
laser fiber, and with the aiming beam at 5, you will see the light. Good, good.
Fine. Pankaj bhai, any other?
Yes, sir. One important thing is that this is not a regular ureteric catheter. This is an angle tip ureteric catheter.
Angle tip.
Okay.
Wood
So
is
what are the advantages of angle tip? Where would you use angle tip?
difficult ureteric orifices.
Mm-hmm.
You can use it for when access is difficult to go into the ureteric orifice, or if there is kink or something.
Yes, kink, tortuous ureters, difficult orifices, large median lobe, laterally placed ureteric orifices. So wherever you need to turn to get the orifice, many a times the ureteric orifice is hostile, means instead of looking towards you, it is looking slightly away from you. So in these cases, the angle tip helps. And like you could go disease wise, but the broadly you will use it for say delivery of contrast material or delivery of any say medications. You could use for navigation of tortuous ureter, and you could use for placement or advancement or exchange of wires.
Yes, sir.
So you see the side two pictures they have given. The lower one is the regular straight tip, the upper one is the angle tip, and even the bigger picture is of an angle tip ureteric catheter.
Yeah.
Yes, sir.
Why do you
So
think you
Vijay,
need these markings on the ureteric catheter?
yes, that is important. Tell us.
So the markings are at every 5 centimeters.
Every
So
5
first
centimeters.
5 single mark, then there will be double at 10 centimeters, 3, 4, 5, and there is again one darker bold mark, and then at 30, and then 35, 2 marks, 40, 3 marks. Like that, the markings are till 50 centimeter, and the last 20 centimeter has no marking.
But why do you need them?
Sir, during endourological procedures, in case we are stenting and we don't have CM, then we can use this as a guide to how much we are going.
If
So
you don't have CM, how do you know that the upper end has reached the kidney?
So we have no way of knowing.
the how will you come to know?
Sir, the patient will complain of back pain if
The patient is under anesthesia. What is the length of the ureter? What is the average length of the ureter?
25.
How much?
26 centimeters.
25 centimeter.
20.
Just remember 25 centimeter. So it can be little less
Yes, sir.
also. Okay. So once it goes more than 20 marking, there are
5
chances
marks.
that you might be in the pelvic LSL system. So in that case, what we can do, 20 to 25, urine should start coming. So once the urine comes, then you are 100% sure that you are in the pelvic LSL system. So even if you don't have X-ray, you have already inserted more than 20 centimeter. Okay. And when the urine starts
Yes, sir.
coming, then you are sure that you are in the system.
Yes, sir.
Dr. Gaurang,
Bolo.
hello. There is
Yes, yes.
another type of ureteric catheter that is called as bulb tip ureteric catheter, which is exclusively used for RGP only.
Yeah, we are showing them. We are showing them all different. Sir is there. Yeah. Sir, Pele, you can tell on this, then we will show the other things. Then you can teach them. Anything you want to add? Pankaj bhai, you want to add anything?
No, sir, I think we have covered this well. Just out of novelty, there is something called as Nadiad bag. Are you aware of that?
No, sir.
So the Nadiad team has published a tissue entrapped bag, and that is made using a ureteric catheter. So while describing ureteric catheter, that is something you could be asked. So you could just check it up what a Nadiad bag is. So for any laparoscopy or robotic case, once a ablative procedure has been done, when you want to remove that tissue with the help of a ureteric catheter, a bag is made. The ureteric catheter helps in keeping the bag open. So putting the tissue inside would become easier and managing the bag will become easier. So this is a very commonly used bag in laparoscopy and robotic procedures.
Yeah.
Yes,
So
sir.
what we are using it, we are using an infant feeding tube. That is also a one of the, but this is much thinner.
True, sir.
Yeah. The Brijesh, other ureteric catheters.
Yes, sir, I will show. 1 minute.
Yeah, sir, you were talking about this, na? Sangvi,
The
sir?
middle one is the
Uddeda?
Yes, yes.
Yes, sir, you can ask them.
This is exclusively used for doing RGP. This will not allow the dye to come back from the sides of the ureter catheter. It will directly go in the system above.
Yes, sir.
What is the third number, the one lowermost among the three catheters called? What is the eye of that catheter?
Ashish, can you tell us all the three different tips? The center one, sir had said is about this one, bulb. The lowermost,
So the upper one looks like open-ended. The middle one is cone tip, and the second one is
it is a closed tip with the eye and the on the side.
eye on the side.
Yes, sir.
So this is called as a whistle tip ureteric catheter.
Whistle tip. Okay.
Okay. So as sir has said, the cone tip or a bulb ureteric catheter is used one for RGP, and then it is commonly used for installation during for caluria.
Yeah.
Okay. Brijesh, go ahead. All these are over. You have done the last time DJ stands, na?
No,
Brijesh?
no, sir.
Okay, fine. Ashay,
Yes, sir. Sir, this is the double J stent. It is made up of polyurethane, and it has circular curved shaped ends on both the sides, and it is available in various sizes and lengths.
it is
The
single, it is
length
it is
it,
double
it is
open
double open ended
with
with
both the side open.
side eyes. Both the sides open with extra eyes also,
Multiple holes
and
on his body, correct?
multiple holes on, yes sir, on the double J curved ends, and its length is measured only from the straight part of the stent and not from tip to tip, and it is classified according to the length and size.
So what are the lengths you get and what are the sizes you get?
Sir, lengths, sizes we get from 3 French to 8 French, and lengths are multiple. In pediatrics, we use the formula H plus 10. So uh, I have seen from 16 to about
So
longest is
16 to 24.
26, 626 is of that.
16 to 24. And then there is a double loop also. So if the person is very tall and the ureter is long, then you can use
Sir,
this double loop, so it can become 26 centimeter also. This J, na, that can be a double loop, double
So
J. But
it is called as
the
a
coil 2
multi-coil
times it is coiled.
stent.
Pardon?
okay, sir.
Multi-coil stent.
Multi-coil stent.
Multi-coil. Okay, sir.
So which guide wire will be used?
Sir, for 6 French, we normally use 0.035 inch guide wire, and for 4 French stand, we will require 0.025 guide wire,
And for
and
point 3
0.018. For
and
3
3
French,
French,
we will require 0.018
yeah,
inch.
0.018. Okay. And what is that red color thing?
Sir, the red color thing is called positioner or pusher.
It is radio opaque or radio lucent?
Pusher is radio lucent.
Hmm?
Stent is radio
The stent is radio opaque
opaque.
and this is radio lucent. Why?
Sir, so we will be able to know its
So
exact
when you are,
position, the
listen,
transition
when you
point.
are not doing any procedure under vision, if you are doing under fluoroscopy, okay, that is a time you can differentiate the distal end of the digestant.
Okay, sir. Yes,
So for
sir.
example, you are
Okay,
putting
sir.
it inside the ureter. Then if both are opaque, you will not realize when the distal end of the digestant has gone inside the ureter. Understood?
Yes.
So this
Yes,
helps in differentiating finding out the distal end or the place from where you are pushing. Okay. And on that also there you have got a marking, correct? The same way. Every 1 centimeter there is one marking, and then every 5 centimeter there is extra marking. Okay, just tell me the procedure, how you are going to put. If I tell you that you do the digestanting of one patient, how you are going to do it? Cystoscopically.
We will first give anesthesia, then give the lithotomy position, then under all aseptic precautions, to prepare and drape parts, and then
No, everything is over. Scope is
get
inside.
rigid
You have seen,
cystoscopy.
beta, you
Okay,
have
sir.
seen the uretic orifice. Now you tell me.
Sir, then we will put the 6 French ureteric catheter near the orifice and not touch the orifice, and Then we will pass the 0.035-inch guide wire, and first put the guide wire in a little in the ureteric orifice, and if it goes easily, then we will we will push the ureteric catheter also inside, and then we will push the guide wire till under fluoroscopy till it goes in the PCS, and uh, then we will exchange out the ureteric catheter, and then load the DJ stent, and then load
The
the pusher,
small
and under
advice.
fluoroscopy.
First of all, first you'll put the glide wire right up to the pelvic LSL system, and how will you judge it? It will be reaching up to the 12th
Coil.
week, correct?
Yes, sir.
And then slowly you put the ureteric catheter up to there. See, urine is coming or not. And then just slowly with a very low pressure, diluted dye contrast, you can inject to delineate the proper pelvic LSL system. Okay. After that, you remove the ureteric catheter and then you put a DJ stent. So you exactly know where you are putting the DJ stent, where it is going to coil.
Sir, in every case, RGP should be done, ideally.
See, when you have already done ureteroscopy and other thing, and you have already gone inside, you know that the guide wire has coiled properly inside. There is no need. But
Okay.
whenever you are doing a blind procedure, you are not sure
Okay. Okay.
because you might have gone
Okay.
submucosal, you might have gone outside the
Correct.
ureter, and it might be coiling along the side of the ureter and pelvic LSL system. How will you come to know?
Yes, sir.
Sometimes it may penetrate the parenchyma, and your upper tip may be in the parenchyma. Patient will have bleeding also, patient will have pain also, stand colic. Sometimes it goes outside the system if it is infected, dilated, thin out system. So it is, in such cases, it is always better to delineate the pelvic LSL system and then put it.
So the answer to your
Yes, sir.
question is yes, RGP should always be done. Means I would go to the extent of saying that first you put a ureteric catheter in the orifice, instill contrast, get the roadmap, then put the glide wire, then place the ureteric catheter up in the PCS, exchange it with a stiffer wire, and then slide the stent over it. And everything should be done under fluoroscopy with retrograde pyelography control.
Yes, sir.
So you got
You
your
can see
answer
the
properly?
three ends of
Yes,
the
sir.
stents,
Yes, sir.
that two white and one yellow stent. There is a difference between the three coils. What is the significance of that? Can you see the three coils are a bit different? Or at least two are
Yes, sir.
same way, the middle one is not adequately coiled.
Yes, sir.
Yes, sir.
So, there was a time when there were two different terms. There was one term was called as a double J stent and second term was called as a double pigtail stent. So if the coil went more than 360 degrees, then it was called as a double pigtail stent. Okay. If it was around 270 degrees or less than 360 degrees, it was a double J stent. But now most of the stents come in the double pigtail format. So the original term of double J stent has remained. The advantage of more than 360-degree coil is that the upward or downward migration of the stent will not happen. So the upper coil will prevent the stent from coming down and lower coil will prevent the stent from going up the PCS.
Yes, sir.
How will you decide the length of the stent in a particular patient? Okay, and before we go there, whenever you are asked to describe the procedure of putting in a stent, don't start from anesthesia, start from saying that I would review the radiological images, see the
Yes.
orientation of the pelvic LSL system, review the consent, and then start the procedure. And that is exactly how you should really be doing when you are placing a stent. Because maybe you have gone placing a stent it's a pelvic kidney and your person in the CM has kept the CM focused in the renal fossa. Okay, so seeing the images before starting the digesting is absolutely important. That will also help you decide which stent to keep open. So if it's say a pelvic kidney or an unascended kidney, you will need a shorter stent. Otherwise, you'll need a standard or a longer stent.
So about size, I will decide. The two methods are there from X-ray KUB and X-ray IVP. In X-ray KUB, I mean, if the KUB image is large enough, then we will just measure the length from xiphisternum to pubic symphysis. And in X-ray IVP, we will measure from PUJ to VUJ, the pelvic-ureteric junction to
Xiphisternum to pubic
vesico-ureteric junction.
symphysis. Where have you read this? कहीं पढ़ा है आपने तो बताइए because I am not aware of this.
See, the originally, when there was a normal X-ray, not a digital X-ray. So the normal X-ray, when they were taking, that time it was almost the, life size X-rays were there. That time, the olden, our professor used to teach us like that how you're going to measure it. That is a way, one of the crude way of deciding the length of the digestant.
So सर ये xiphisternum जो कह रहे हैं ये आपको ये सही लग रहा है क्योंकि मुझे सही नहीं लग रहा.
Xiphisternum to this thing, not xiphisternum.
What
It
I
is the
remember reading is it is from the transverse process of L2 vertebra till the iliac tubercle. Iliac tubercle or yes, iliac tubercle. You draw a straight line and that gives you the approximate length of the stent. If you want to check it from X-ray KUB. But these days, conventional X-ray KUBs are not done. So this has become more theoretical. Okay,
Correct.
again, the approximate guide would be based on the patient's height. So
Correct.
for a
I was
5
about to
feet
say that,
patient,
sir. We had that chart in RG, no? That we have
yes.
taken it from Smith's Endourology.
Yes.
So we had that chart that according to height, we used to see the stent. That is more used nowadays because, like you said, sir, X-rays have changed completely.
True. So for a 5 feet patient, approximately 20 centimeter stent. And for beyond that, every inch that the height goes up, you increase the length of stent by 1 centimeter. But these figures, I request you to reconfirm. I have not read these figures for a long time. So you please reconfirm whatever is given in the Smith's textbook and answer accordingly.
Okay, sir.
Fine. So what are the uses? Yes.
Uses of double J stents are in cases of first in infections for drainage, then in urolithiasis after procedures like URSL and PCNL for post-operative drainage,
Mm.
and then in cases of malignancy where there is extrinsic compression for drainage, and
then when you want to
in cases
identify
of
during
stricture infections like tuberculosis,
okay.
strictures.
Yes.
And
Then
ureteric reconstruction after ureteric reconstruction. Or renal
Yes,
transplant.
in cases of ureteric injury, after ureteric repair, in cases of all reconstructive procedures, like, in pyeloplasty also.
pyeloplasty, reimplantation of ureter. Then when you are doing any pelvic surgery, another gynecologist or onco, then they want to secure or identify the ureter. You can do the stenting. Then
yes, sir.
And
Then
RPF.
in cases of transplant.
Yes, sir has
Yes,
said
sir.
in
Yes,
cases
sir.
of transplant.
Hello.
Yeah.
RPF, retroperitoneal fibrosis.
Yes, retroperitoneal fibrosis. So, can you just enumerate one of you, Akshay? Can you just enumerate properly?
We can divide it in intrinsic, intramural, and extrinsic. So intrinsic will be any stones or papillary necrosis. Then we can pass a stent to relieve obstruction. And intramural, any ureteric mass. Then any procedure, ureteric injury or reconstructive procedure of the ureter. And then extrinsic compression by various pelvic masses or retroperitoneal tumors. In those
Already.
cases, for drainage, we can use double gesture.
But first, you must tell after doing
Endourological procedure.
Endourological procedure.
URSL PCR, RRS.
Yeah. I think systematically you should write down once in your logbook or somewhere, like, so that you remember forever. Right.
Yes, sir.
Yes, Pankaj bhai, anything else you want to say?
Oh, sir, stent we can discuss for 2 days.
I know.
So,
Okay.
yeah, आगे बढ़ना है या इसी पे रुकना है sir?
Yeah. If you want to finish this, then we have got another last lecture. We can take it the upper tracks also, no problem. One more
So, okay.
clinic we will take.
What are the various complications of digestant?
Displaced
It can be
digestion.
classified as intraoperative.
Come again, I couldn't hear you.
So one is during the intraoperative procedures for devious stenting,
Mm-hmm.
it can enter the false passively. You have not kept the guide wire in a proper position,
Okay.
or when bleeding can happen, then misplaced devious stenting.
Okay.
And post-operatively, misplaced devious stenting, or it can migrate
What's
its
the
stent.
commonest complication you see after stenting?
Infection.
Not necessarily infection.
Dysuria.
Stent-related pain.
Stent
Stent
Yes,
dysuria and
yes,
stent
yes,
pain.
yes, stent dysuria. Yes.
Okay. Practically every alternate patient will complain of stent dysuria and stent pain. Okay.
Yes, sir.
Other than that, there can be hematuria, there can be malposition, encrustations, fragmentations, migrations, which could be antegrade or retrograde. Extrarenal placement can lead to subcapsular collections and subcapsular hematomas. Okay.
Yes, sir.
There are multiple reports of extrarenal malposition which leads to stent getting migrated to vascular system. So I would feel start from the commoner ones to the more rarer ones. So start with pain, UTI, then migration, encrustations, fragmentations, and then go to rare ones, including
Hematuria.
Stone
Hematuria.
and with neglected double stents.
Yes.
Okay,
So
what can be done to prevent the post-op stent dysuria?
So the length should be properly calculated for stenting. It should not irritate the bladder neck.
So how would you know that the stent is properly placed? So where should the coil be?
It shouldn't cross the ipsilateral half of the
Yes, it
bladder.
should not cross the midline. Perfect.
Yes, sir.
So a well-coiled stent which should be on the same side of midline. It should not cross the midline.
Yes, sir.
And then, so this is while positioning. So a proper size of stent with a proper coil placed on the same side of the trigger. Okay, then post-operatively, what all can you do to reduce the pain?
Medical management with alpha blocker and bladder relaxant. tamsulosin, solifenacin.
Perfect. Okay.
Yes,
And ठीक है. Are you aware of any, say, what are the innovations in stent technology? What is a magnetic stent?
no.
Know it or not?
No, sir.
Pankaj
Okay,
bhai,
so
you'll have to tell.
magnetic stent has a small metal at the end of the stent, and there is a magnet at the end of the say pusher. So when you want to remove the stent, you just insert the pusher blindly into the bladder. So the magnet will catch hold of the metal at the end of stent, and you will not need a cystoscopy to remove the stent.
Yes.
So so there is a lot we can talk. I think let's move forward.
Okay.
Hmm.
Now,
So
last question I want to ask them.
among the innovations, you should know about magnetic stents, you should know about metallic stents, you should know about biodegradable stents, you should know about drug-eluting stents.
Yeah.
So a lot of
And
work is happening in biodegradable stents. The biodegradation can happen as early as 3 days to maximum around, say, around 6 weeks. So depending on what the indications are, say if you have kept just for post-operative inflammation, then you will keep a stent which gets biodegraded in 3 to 7 days. Then there are drug-eluting stents. These stents are used for UTUC. So there are stents which have, say, what is the drug? I think mitomycin coated drugs are stents are there. So there is a continuous release of mitomycin from these stents. So used for nephrospastic procedure for UTUC.
Yes.
okay, Ashai, this normal
Yes,
stents,
sir.
how many days you keep in your institute? After urolithiasis, after any reconstructive procedure, and in case of stricture, just tell me.
Sir, in normal urolithiasis, we'll keep it for 3 to 4 weeks. And in reconstruction procedures like pyeloplasty or reimplantation, we'll keep it for 6 to 8 weeks. In stricture is also same, 6 to 8 weeks.
So in stricture and
In the institute.
uretic injury, how much you keep?
6 weeks.
Maximum 3 months. Okay, fine. Or you can take the different stent, which is silicone coated, which you can keep it for the
Silicone.
longer period of time.
1 year. Yes, sir.
Yeah.
6
Now,
months.
my question to you is, in your institute, what are the steps you are taking to see that it doesn't become a forgotten stent?
Sir, so in my institute, we first, while explaining the consent, we tell the patient that a foreign body will be placed in them and they have to get it removed within 3 months. And then if it is under spinal or local, we show them on the monitor or on the screen that they have this. And there is a post-op X-ray, which also we show them and tell them to if they go somewhere else to their hometown, they can show that X-ray to any doctor. And also we stamp the discharge cards and during discharge also explain that patient will be responsible for the complications if the stent is kept for more than 3 months. And we also have a diary maintained of DJ stents with the patient's numbers. So most patients are appointed and come on time, but if someone doesn't come, then we can just call them.
Fine.
So
Good.
these are the measures in my institute.
Yes. So nowadays you can SMS them, you can email them, you can telephone them, whatever it is. But primary responsibility lies on, at least in USA, it is like that. It lies on the surgeon. Okay, you have to prove that you have taken enough of effort to inform or call patient for DJ removal. Otherwise,
Yes, sir.
You understand? So in USA, it
Yes,
is
sir,
like
yes.
that. In India, yet it has not come. But sooner or later, it is going to come. So you have to, you said very rightly, you must telephone. So, or you write a letter if he doesn't have telephone, or, you know, if he has got a phone, you can SMS, which becomes a proof that yes, you have called him, like that, or WhatsApp.
There is a app also, sir. Website also is there for
Exactly.
ureter stent track and track.
Correct. Correct. Very good. Fine. Okay. Brijesh, go ahead. Yes, Akshay. Fadafad abhi, come on. What is this?
So this is
Yeah, tell. You're right. Come on.
spiral
Tell.
spiral tip ureter access catheter.
Hmm? Suhas?
Not sure. So is this metallic? Not sure.
Yeah, barabar hai. Tell, na? Proper.
Metallic
It's a
TJs.
metallic. Yeah, it is a metallic double J stand, na?
Yes. Okay.
Yeah, Hiren, you know? Hiren, can you tell them something? Because you know more about this.
Sir, metallic stents are used in conditions where we are suspecting that the ureter may collapse or get external compression, like in cases of malignancy or some retroperitoneal tumor or something like that. And this metallic stent has to be placed in a special way. So there is a outer sheath that is present over this metallic stent. So first that sheath is placed. It's like a ureter catheter, but it has a very thin sheath over it. And then we remove that ureteric catheter, or we can use the ureteric catheter to do RGP, and then put the stent inside. And once that sheath is withdrawn, then this coil takes the shape inside. There is a
Very
small
deep.
video
Yes.
on YouTube which you should watch it, how to place this stent.
Yes, sir.
Okay. Maheshwari ji,
These are,
you know anything about this? If you want to
yeah,
add.
these are called as resonance stent. It's a fully metallic stent. It does not have a lumen. It drains by the spiral on the stent. And the in vivo life of this stent is around 2 years. Okay, and
Okay.
as Dr. Hiren has said that it has a very special way of placing it. You first place the placement sheath and through which you place this. Hiren, if I remember it right, this is 8 French, no?
Correct, sir. Correct.
Yeah. So the smallest size that comes is 8 French.
Fine.
So
See, you
any
know so much
patient where
about.
you feel that you need a long-term stent because of malignant obstruction, this is a good stent to place. The only drawbacks are that one, it is very expensive. Means last when I checked, it was around 1500 US dollar. And second is some patients, around 10% patients may not tolerate this stent. So I have had one occasion in my career where I placed a stent and second day the patient was so unhappy that we had to remove it and placed a regular stent. So these are the two things you should be aware of while placing the stent. So more often, first time you would place a regular stent, let the ureter open up a bit. Next time this larger stent would go in and then this would stay for a long duration of maybe 18 to 24 months.
Yeah. So even if there is a long stricture, in that case also, you know, when you don't want to do any reconstructive surgery or patient is not fit, then you can put this stent.
Yes.
Very good. Brijesh, go ahead. Just tell us.
This is a silicon
Silicon
double stent.
double J stent.
Fine. And maximum how much time you can keep it?
6 months to 1 year.
10 to 12 months, correct?
Yes.
Yes.
And why the pusher is like this? This is distal end or proximal end? Proximal towards you or proximal toward means or distal towards you from you? It is a proximal towards you or a distal end. Okay. And why it is like this? Okay. At the other end, there is a metal. Why it is like this? Why there is a metal on this red pusher? There will be a small ring. See, this stand is not very clearly visible. It is radiolucent type. Even the pusher will be like that. So how will you make out the junction between these two? So this metallic strip. So it will
Okay.
tell you where the DJ stand is ending and where the pusher is starting. Second thing is this. Once you put it on a guide wire, so you put a glide, if you want to put a guide wire, and on that you want to fix DJ, then you put this pusher and screw the distal line. So the whole system will stay in the place. And then you can, over the guide wire, with a soft end inside, you can push it into the system. Okay, this system you will not get in normal pusher.
Okay. Yes.
Yeah. Okay. Brijesh, go ahead.
This is a bevel tip PCM needle, sir.
Okay.
18 cards.
Now, only thing is, I'm not sure because when I was, we started surgery, we used to call it Gunter, 3-part Gunter needle.
Okay. Yes, sir.
I think he can enlighten us. Dr. Maheshwari, I used to remember this as a 3-part Gunter needle.
I'm not sure about the name, sir, but yes, we used to use a 3-part needle. These days we use a 2-part needle.
Fine. So tell us, what are the 3 parts, Ashay?
The 3 parts is that is the inside one is the needle, and inner sheath is a long inner sheath, and the inner sheath is of 21 card size, where the outer sheath is.
So outer one is
Outer
the
sheath
sheet,
18,
then
short.
there is a needle, and inside there is a stillet.
Yes, sir.
Okay, the stillet prevents any tissue getting embedded into the beveled part of the needle.
Okay. Yes, sir.
So if you want to aspirate, so you just remove the stillet, and if you are in the system, you will get the fluid. If you are not in the system, again you put the stillet, it will clear up the tissue, and you go further inside.
Yes,
Correct?
Yes, sir.
Yes, sir.
Fine. Okay. How you sterilize it?
But it is a disposable needle.
Yeah. So ideally it is a disposable. So in exam say it is a disposable needle. Just a practical question I want to ask. Okay. Suppose if you don't have this needle, what you will do? Suddenly you have started the case and you don't have this needle, what you will do? Already anesthesia is given, or you have got a needle and you have lost it. That's the one practical thing. This is just to not to answer in exam. I just want to tell you. Couple of time I have done it.
long lumbar puncture needle, if we can get of, I means black needle
Yes,
is 21
but
gauge,
what
then
is
we
the
can put the 0.01 wire, or if we
put?
get
Yes,
18 French, then we can put 0.035 wire through it.
no, normal also 0.38 will go. Now I want to ask you only one question. What measure you will take when you by chance you have to use lumbar puncture needle? What is the difference between that is two-part puncture needle and lumbar puncture needle? What is the difference? There is no sheet,
Yes, sir.
obviously.
Yes, sir.
Okay, so what happens? It is a beveled. So if you try to manipulate your guide wire, it will damage your guide wire and it will strip it. So you can insert it, but you cannot pull it.
Yes,
If
sir.
you try to pull guide wire, there are chances that the sleeve will come out and you will keep, it will remain inside the system. So when you're doing this, it is very difficult. Understood?
Yes, sir.
Yes, sir.
Sometimes you can try with the old guide wire outside the system, like, in the on the table or something. You try it, push it inside and pull it out and see what is happening.
Yes, sir.
Okay. Maheshwari ji, anything else you want to ask?
Okay, how will you place a safety guide wire?
If we want to use it through the same puncture, then we will have to use the Alchem's needle and cannula. The Alchem's needle, or we can take another puncture for a safety guide wire.
No, you cannot take another puncture. You will have to use a Alken's needle or Alken's cannula. So
Yes, sir.
once you have made a puncture, you put in a guide wire, then you put the Alken's cannula. Through that, put one more wire, and then on one
Yes,
of the
sir.
wires start dilatation so that the other wire becomes a safety wire.
Yes.
Right. Another earlier we didn't have all these things, na? What we used to do is that, for example, we dilate it to 10 French or 12 French. And then we used to have one of the 10 French where the tip was little cut off. So the lumen becomes little bigger. So after dilating to 12 French, okay, we used to put this 10 French, the tip which has been cut off over the guide wire, which will go into the system, and then put another guide wire. So it will accept both the guide wire and then remove it and then dilate with one. That was earlier we used to do. This is just one of the practical hint I'm giving you. Again, not to say in exam. You understood now what I'm telling you?
Yes, sir.
Yes,
Cut
yes,
the
sir.
facial dilator.
Yeah, so the dilator will allow only the lumen is only for 0.035, correct?
Correct, sir.
Then it is a conical. So if you cut it little proximal, the lumen will become, the distal end will become broader. And two guide wire
Yes, sir.
can
Yes,
be
sir.
passed. Okay, fine. Next, Vijay.
So, these are the facial dilators, which are made from PTFE, polytetrafluoroethylene. They are available in sizes of 6 to 16 French. They are used for in PCNL for dilatation of tract after the puncture and after the placement of safe guide wire to the puncture. And it has the parts are the conical tip and the opening, the proximal opening, which will accommodate the guide wire and the shaft.
And there is a lower lock, na, at the other end.
Lower.
Yes.
Why you need it?
Sir, sometimes if we need to push dye, then it will attach properly
Yes, to
for
aspirate also to find
visualization.
out whether you are in a system or not. One thing, and
Yes, sir.
second thing is to inject the dye both the way.
Injection. Yes, sir.
That contrast, say contrast. To
Yes, sir.
inject the contrast. Fine.
Yes.
To aspirate.
Yeah. And how you they are also one time use, but how you sterilize otherwise?
2% glutarate.
No, you can have multiple system, na? Gas sterilization or ETO.
ETO plus. Yes, sir. And these are
Want to add
sequential
anything?
dilators.
Hiren, you want to add anything? Dr. Udeda?
No, sir.
No,
Okay. Fine. Yeah, Brijesh, next.
This is a screw dilator. It is a facial dilator with a screw shaped tip, and it 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 comes in various sizes: 612, 614, 618.
Okay.
And
What is the
it is
advantage?
useful. Sir, it is useful in redo cases where there is fibrosis,
Hmm.
and it is a single step, so there
Single
is
entry.
lesser chance of bleeding. So the tamponade effect is not lost, which is seen in sequential dilatation.
Okay.
More than the temporal loss, I would be more worried about the slippage of wire when you are exchanging the dilators. So the repeated
Yes,
exchange of dilators is not needed. And after a single step, you can directly take a guide rod.
yes, sir.
And another thing is that normal dilator, na, you have to, when you are putting it inside, okay, you have to screw and unscrew in both the direction you have to move. Otherwise, the tissue
The tissue will
will
get
get wind
entangled.
up around it and it will not yeah. But here, because there are spirals, okay, it's a screw system, so it will cause less damage to the tissue and it will go inside. Easy insertion comparatively. Fine. Then there is the bottommost. What is that bottommost one? Dilator. Can you see the tip? It is little different. That white one. Any guess why it is like that? And when you will use it? Ashay. See, when the guide wire has not gone into the ureter, pelvuretic junction, with this you may be able to manipulate. Okay? And
Yes.
this you can put at the PU junction and from there you can push it. I have never used it. Maheshwari ji, आपने use किया है?
नहीं sir.
नहीं. Yeah. Fine. Brijesh?
These are the metallic
Alkene dilators. Metallic.
telescopic dilator, Alchem, which consist of one central rod and various metal dilators, which are uh, uh, which are in sizes from 9 to 24, 9, 12, 15, 18, 21, 24, and even up to 30. And the rod is 58 centimeter.
Okay.
7 feet size.
And
9 centimeter.
the rod has two ends, one beaded end and one conical end.
What is the size of the bead?
9 French.
The size of the bead is 9 French and rod is 7
Why it
French.
is 9 French?
Because the first dilator should not overshoot. That's why the bead is 9 French. It snugly fits, and there is a ring inside, so the other next sequential dilators don't go ahead of the beaded ring.
Why the other dilators doesn't shoot? Go ahead. Which
There is a
mechanism?
ring inside
Which side?
which
Which
traps
side? Which side?
the the patient side.
Patient side. The first dilator is
Sir.
stopped by the bead. Okay.
Yes, sir.
But subsequent dilators, they have got a distal end, they have got a ring. So the proximal end can go very easily.
Yes, sir.
And then there is a ring which stops that dilator to go further.
Yes,
Use
sir.
your
Understood?
common sense. Now, if there's a ring inside, how will the dilator go?
From our end, there is a yes, sir.
So that is the reason when you remove the whole system from the implants,
Hmm.
don't hold the dilator. Otherwise, everything will fall
Rod.
down. But if you hold rod, nothing will fall down.
Yes, sir.
Understood?
Yes, sir.
What is the advantage of these over the serial serial dilators?
Sir, the tamponade effect is not lost. So there is lesser bleeding,
Mhm.
and it is rigid. So
Yes. So buckling of the guide wire. Otherwise, if you
buckling
put
of the
it,
guide wire or thinking of the guide wire in if the tract is not straight.
yes, here the track will be straight. Okay, there will not be a false passage, right? The
Sir.
bleeding will be less. Tamponade is better.
Yes, sir.
Correct?
Yes, sir. And there is a rough surface for the grip also. Yeah.
Okay.
We can use the unscrewing motion.
Yeah. How will you find out the proximal and distal end? If I give you on your hand, in your hand.
Sir, for hand grip, there will be a rough surface,
So that multiple, yeah, the
multiple
spiral,
rings.
yeah, rings and like threading is there. Okay.
Yes,
The
sir.
distal end has got a threading. So you know it. Because why? So that it doesn't slip and you can rotate it nicely and push it inside.
Yes, sir.
Okay. Fine. So what are the complications? And first of all, how you sterilize it?
For 2% glutaraldehyde.
Array autoclave it.
Autoclave, sorry.
And how will you clean it?
Sir, by flushing it using a
First of
20
all, you
ml
will
syringe.
separate all the dilators. Then you will clean it properly. Okay. With a
Yes, sir.
sterile water. And if you want Savlon or any other, disinfectant, then in a syringe, you take the material, fluid, and flush each and every dilator and even the
Rod.
rod. Okay. Then pass the oxygen or the air and dry it and see that it from outside also and from inside also it is dried properly.
Fully.
Then pack it and then you can autoclave it.
Yes, sir.
So anytime this kind of question is asked that how will you clean it, you have to tell the answer in several parts. So first is the pre-cleaning. As soon as instruments are removed from the patient, you have to remove all debris and blood clots and all organic material from any instrument. That is called pre-cleaning. Then it is flushing either with distilled water or enzymatic solution. Then you wash the instrument. Then you dry it, including all the channels, like Sir said, either with the air gun, or if you don't have that, you can use your oxygen cylinder and a tube and flush it all out. then storage, and before doing the plasma, you will pack the instruments, or before doing autoclave, they will make the tray and autoclave it. So all these are the steps in flexible or other instruments which are heat sensitive. They are hung overnight so that all the moisture drops out, and then they are done plasma sterilization.
Yes, sir.
And suppose they ask you that any good way of disinfecting, not this instrument, but the heat sensitive instruments, then disinfection can be done with 2% glutaraldehyde, which we have been doing all these years. But something better is sodium perboate, which is called Paradex. It is available by Microgen, and it can be reconstituted every day. So between cases, all the other steps have to be followed: pre-cleaning, cleaning, flushing, drying, leak testing, and then you put it in Paradex. But that is not the best way to sterilize. The best way is still plasma, as well as PTO, as well as autoclave.
Okay, so dilators are over. Brijesh? No, last dilator. Show. Yes. Chal, Akshay, you tell this, and then we conclude. Next time we will do the scopes.
So this is the employed system of dilators, uh, along with some facial dilators also. And there is one Cobra catheter, and the employed dilators, which are uh, there are three facial dilators, and the employed dilators, which are starting along with employed sheath. They range from 12 French, 12 and increasing by 2. So 12, 14, 16, 18, 20, 22, 24, 26, and up to 30 French is also available. And in the employed system of dilatation, over the guide wire, first the Cobra catheter is put, and over that, sequentially, uh, we insert the employed dilators from 12 to whichever size is desired, 24 or 26 for PCNL, and though that sheath is put sequentially. So,
Okay. The disadvantage?
but the disadvantage will be, so the rod is more rigid and stable. So the during if there is a kink in the path, then it will be difficult to negotiate using the amplats wire. The dilatation tract should be straight for this.
Also, every time you remove it, there is a bleeding. Less
And the
tamponade.
tamponade effect is lost. Yes.
Yeah. Okay. Maheshwari ji, I have hardly used it. Have you used it?
Even my favorite is Elkins dilator, sir.
Yeah. Some people,
We
I have seen some people using, like, the large dilator directly without, like, just they dilate,
As
and
the
instead of
single
serial
step dilator.
dilatation, pardon?
Single step dilatation.
Single step dilatation. And I have seen the way it bleeds quite a lot. I don't advise anyone to do that.
The
Do very
only place where we
systematically.
use the inside blue dilator is, sir, when we are outside. So that we all regularly use.
Yeah.
Suppose we have under dilated, then we use the blue
Then is
dilator.
okay.
Yeah.
After doing regular dilatation, if you're under that, then we are using it.
Correct,
Or
sir.
when your PCNL is done and you are doing the relook second
Yes,
time,
sir.
then again you can use it.
That is when
So
the track is already formed. Then you just put
already
guide
formed.
rod, put the blue
Yes,
dilator, and slide the amplat sheet over it.
correct. Fine. Anything else? Brijesh?
That's it, sir.
Done, na? I think
Yes.
next time we'll finish the upper track. Okay.
Perfect. Perfect, sir.
Okay.
Good night, sir.
Thank you very much
Sir,
for all your input.
Good night, everybody.
Good night, everybody.